Morning, everyone. My name is Paul Spiegel. I'm director of the Center for Humanitarian Health at Johns Hopkins University and a professor there, as well as a chair of the CHA Science Commission. We're really thrilled to have everyone in the room and also online. We are going to jump into it because it's a packed agenda. Just to explain what we're planning to do today, we'll start with Anna Mateus and Richard Horton of the Lancet, who I can see are joining us via Zoom. We will then move towards, I will give a 20-minute presentation of the commission itself. Then we'll move to David Miliband, who's the CEO of IRC, the International Rescue Committee, will give a keynote talk. And then we will have two panels. Panel one will be chaired by Dan Maxwell, and this will be hearing from the commissioners and the next generation. And then the second panel will be some distinguished guests, some of whom are on the advisory committee, others were not, to hear their views. After each panel, we'll take some questions, and then we will likely go till about 1:15, and then we will go to the 9th floor, and you're welcome to join us for a reception. So with that, it's my pleasure to introduce Dr. Anna Mateus, who's the executive director of Lancet. She brings deep editorial expertise across the biomedical sciences and peer review. Anna was really our guide for the Lancet for this commission, and without her, we wouldn't be here. So a deep thanks to her. And then we have Dr. Richard Horton, who's the editor-in-chief of the Lancet. We work very closely with Richard, also on the commission and on various other aspects in humanitarian health for years. So without further ado, Anna, and then Richard, over to you.
Thank you, Paul. Can you hear me well?
Yes, hopefully we'll be able to.
Yeah, I'm really sorry I can't be there in person, but it's still a pleasure to join remotely this second global launch of the Commission report, following a very successful and inspirational launch in Geneva. It was truly a privilege to work on this Commission from the Lancet side, and I would really like to congratulate again all commissioners, and in particular Paul for your leadership, and also the co-chairs, Carl, Esperanza, and Chichi. I also want to thank the reviewers who provided very thorough and constructive comments, and all my colleagues at the Lancet who ensured we could publish this report on time. When the discussions about this commission started in mid-2023, the world was quite a different place. But at the time, the humanitarian system was already overwhelmed and fit for purpose. And for too long, aid had been driven by political and economic interests, with a few powerful actors setting the agenda, centered around a complex of international humanitarian and development organizations lacking coordination and failing to prioritize the dignity and health of affected populations. Previous attempts to correct this had been diluted by power dynamics and fragmented agendas. Violations of international law and humanitarian principles have become normalized with impunity. But amid unprecedented humanitarian needs and recent funding cuts, change is now inevitable. And ironically, by shaking the entire humanitarian system, the current crisis creates the conditions to fix it. Destroying it, as many might want, is not an option. 239 million people need humanitarian assistance. And estimates published by the Lancet show that abrupt changes in aid can cost millions of lives. At this important juncture, the Lancet Commission report provides a comprehensive argument and roadmap for radical transformation towards a more just, robust, and sustainable humanitarian system. This was achieved through an integrated and scientific analysis of the system's fundamental structures, as well as through the Commission's humility and self-analysis and a sense of mission so deeply imprinted in their DNA. This was not just an academic exercise. It was centered around the voices of those affected and their realities and anchored in humanity. At the core of this manifesto is the need to invert power and focus on populations, something not limited to humanitarian aid and so relevant to the ongoing discussions around global health governance. As we live through some of the darkest moments in recent history, stuck in what feels like an endless interregnum, a new world can emerge. The moment calls for courage and leadership from countries, particularly middle powers, to come together and support this effort to transform the humanitarian system. Beyond the moral argument for shared humanity, we now live in an interconnected world, and as shown repeatedly, crises such as climate change, pandemics, war, and migration have no borders. Global health is national health. International solidarity serves long-term stability that benefits everyone, and compared with national budgets and defense financing, it costs little. Above all, we must not be nostalgic about the past. We should be hopeful about the future and excited about a reform aid and humanitarian system that confronts power and incentives and truly prioritizes populations and human health, laying the foundations for pluralism, coexistence, solidarity, and humanity that transcend humanitarian action. Over to you, Richard.
Richard, you're muted, sir.
Sorry, Richard, your microphone is off.
Sorry. Let me just thank Paul and Esperanza, Shishi and Carl and the whole team for producing what is a tour de force. And let me also thank Anna and the whole team from the Lancet for your intense commitment to get this project through to publication. I just want to quote one statement in the peer review of this commission, which Paul said at the launch in Geneva he didn't recognise, but I want to remind him and the whole of the audience. One of our peer reviewers described the commission as a masterpiece of analysis, synthesis and vision. So let's remember that as we listen to the next 2 hours. It really is an extraordinary piece of work. Just a few very brief points, please. The first is that we're not dealing with a static situation here. The nature of humanitarian crises is changing and changing quite rapidly. We're seeing protracted violence of civil wars. More recently, we've seen wars of total annihilation that are seemingly legitimized by the international community. We're seeing the introduction of artificial intelligence tools into the technology of weaponry and war. And of particular interest to us as a scientific journal, we're seeing the weaponization of information. So this commission is confronting a highly dynamic situation, which makes the afterlife of the commission, what we do now after publication, so important. And after seeing the presentation of the commission in Geneva, I think you're all going to be highly impressed by what the Commission has planned coming next. Second, you're all sitting in the comfort of a very nice lecture hall. I'm sitting in the comfort of a room, not with you, I'm afraid. But we should be very conscious of the operational realities of humanitarian work and the practical constraints that face an effective humanitarian system. In conflict settings, there is little evidence at the moment that impunity is going to diminish, unfortunately. Violations of international humanitarian law have continued without any meaningful consequences whatsoever. And the humanitarian system, as you will hear, has become unfit for purpose, not because it's fundamentally wrong, in a sense, but because it's been overwhelmed by external realities. So that's the scale of the challenge. And then that just brings me to my third point, and that is the great strength, I think, of this commission is the way the elements such as community engagement, governments, local systems, health system capacity, financing, how all these elements are brought together into an integrated whole. That's the great success of this work. The challenge now, of course, is action, implementation. and what are the political pathways through which the Commission's proposals could be achieved. We need the concrete detail of how. The Commission provides the what, and now we need to think about the how. In other words, what we need is a political strategy to translate the Commission's recommendations into reality. What I can promise from Anna and myself and the team at the Lancet is that we have got a long-term commitment to Paul and his team in this initiative. We want to provide you with a platform for advocacy, for convening, for further work to bring the vision of this, if I may say, extraordinary initiative to realization. So let's get on with the main show, and thank you very much indeed for joining.
Thank you, Richard, and thank you, Anna. If we can figure out how to bring up my slides, that would be great. I'm slowly going to get this technology down. There they are. Okay, perfect. Okay. Thank you, everyone. So it's a privilege to be here at Johns Hopkins Bloomberg University Center to launch the CHH Lancet Commission. We did launch it on May 20th at the World Health Assembly in Geneva, and this is going to be the North American launch, and then we will have numerous other launches throughout the world, and hopefully those of you that aren't able to join will be able to join those. That will be in Nairobi, Amman, Dakar, and Colombia, Bogota. So our title is Health in a World of Crisis and Impunity, and that title is deliberate. It names two things at once: the crisis itself and the failure to enforce the protections that we already have. Health in a World of Crisis and Impunity is not a neutral title. It's the problem that we all must face. Next slide, please. So between 2021 and 2024, conflict-related deaths have nearly doubled. In 2026, 239 people were in need of humanitarian help, but only 87 million, or 36%, have been prioritizing. And this is rationing by design. $23 billion would cover the world's most life-threatening humanitarian needs. That's less than 1% of the global military spending. The money is there. What is missing is the political will. The system meant to respond has been gutted at exactly the moment that the need has peaked. Next slide, please. So this is a long view. In 1980, forced displacement was a relatively small phenomenon. Today, more than 123 million people are forcibly displaced, the highest number ever recorded. Look at the line after 2011. Syria, Yemen, South Sudan, Tigray, Ukraine, Sudan, Gaza. Each rise is a political failure that has become someone else's personal and permanent reality. Displacement now lasts decades. A system built for short emergencies is being asked to manage what is in practice life sentence. Next slide, please. Attacks on healthcare workers, attacks on hospitals, on clinics, attacks on supply chains, patient transport, all are rising fast and relentlessly. In 2024 alone, Security Insight, this is unpublished data, now it's published in our report, reported that there were 3,663 attacks. That's 18% more than in 2023 and 58% more than in 2022. And these are only the attacks we know about. The real number is almost certainly much higher. In Sudan, 70% of the health system was destroyed in the first 6 months of the war that began in April 2023. In Gaza, hospitals were systematically and deliberately targeted. We see the same pattern in Ukraine, Myanmar, and elsewhere. Attacking hospitals is not a tactic of war. It is against the law. Condemnation without consequences has really sadly become the norm, as Richard has said, and simply not acceptable. Next slide. And here's a picture of who actually controls the response. The grand bargain promised that 25% of humanitarian funding would go to local actors by 2020. Nearly a decade later, we're still very far from that. In 2024, 95.7% of direct humanitarian funding went to international actors. Only 4.3% went directly to local and national actors. This is not a technical failure. It's a failure of power, trust, and resources. Next slide, please. And here's an equity picture in the past 15 years. This one actually is quite important because I want us to really focus on the 10 largest humanitarian emergencies, which produce 55 to 75% of the world's IDPs and 64 to 80% of all refugees. And these, for the most part, are the same emergencies year after year. And yet these same crises received only 29 to 50% of the humanitarian funding. And the gap was held relatively stable across 15 years. Yet in some years, some of the differences was actually a 40 percentage point. And this is a structural issue. It's not anecdotal. If we focus on these actual 10 emergencies, we can have a huge effect. Next slide, please. So behind every statistic on those data slides is a person, and this commission worked hard to listen to them. These images come from a photo voice study with displaced Syrian youth in Turkey. At the top right, we have 12 years after displacement. A young person is still living in the shadow of an earthquake. In the middle, isolation in a school where she has no one. At the bottom, a pot of food brought by a Turkish neighbor when her mother was sick. Solidarity captured in a single object. We wanted the voices of people that the system is meant to serve to shape both the diagnosis and the recommendations. Next slide, please. So our work took more than 2 years, 2.5 years. It involved 21 commissioners, some of whom are in the room today, and 21 next generation scholars, also in the room today, and you'll hear from them in the panel one. The next gen scholars, we really wanted, it was that the commissioners chose a younger person who will be the future leaders in the humanitarian field, but also to get their perspective, as it is quite different from some of the older folks like me. We had an advisory committee of 29 experts. They included donors, UN agencies, and other multilateral organizations and NGOs, some of whom are in the room as well today and will be on panel 2. And we interviewed 533 affected persons and healthcare workers across 12 countries. That was essential. A lot of the quotes that you'll be seeing are from those people throughout, and they had a big effect on the commission and our findings. We had 13 thematic working groups and multidisciplinary expert reviews that strengthened the analysis throughout. And our ambition was structural. We wanted to rethink the strategies, governance, and delivery of humanitarian health. Some of you may think, well, the Lancet Commission will focus just on health, on non-communicable diseases, on very specific to health. But we recognized early on the system is so not fit for purpose that we're not going to change health outcomes if we don't actually address the whole system. So that's what we tried to do. So it was quite a task. We realized early on that we needed to change a system. We needed to provide recommendations to fundamentally transform, not incrementally change the system. So this is not another call to do better. It's a call to do differently and to do so now. Next slide, please. So this is our conceptual framework, and I'll walk you through it in 3 slides. We anchor the response on the people themselves. And again, that may seem obvious, but the system is not actually, as we know, anchored towards the people. It's anchored really starting with donors and international organizations. The heart of the framework is the person, not the agency. We then move to humanitarian development, and throughout we talk about the humanitarian development peace nexus and the ecological environment, and climate change is another cross-cutting issue throughout. On the left are the drivers of the crisis: conflict and insecurity, forced displacement, public health emergencies, climate-induced events, and other drivers of conflict and violence. We then put them into 3 crisis typologies. And I think this one is important as well because we deliberately develop these typologies in order to look at who the actors are and their legitimacy. So we have new acute emergencies, which are relatively rare, but when they occur, especially if they're not acute or protracted, they're new, we don't necessarily know the legitimate actors and the capacities of all the NGOs. We have acute on protracted and then protracted emergencies. In those situations, they're the large majority are emergencies of that sort. And we do know, for the most part, who are the legitimate actors as perceived by the community. And we do know the local NGOs, and we know their capacities as well. So all of this affects the health of people, or what we call humanitarian health. Next slide, please. So across all of this sits our five strategic drivers. We did have six, and at the last minute we had to move technology and artificial intelligence because of the length of the actual commission, and we put that into the health component. So we have international law, we have humanitarian principles, governance, financing, and health systems. These are levers, and every recommendation that we make in this commission will pull one or more of them to ensure that all of these elements are integrated throughout our four large recommendations. Next slide, please. And finally, we have six themes that run across everything we propose: social determinants of health, populations and conditions of vulnerability, community engagement and accountability to affected populations, data and evidence, technology, including artificial intelligence, and localization. So these are not chapters in the report. They're threads in every recommendation that follows. Next slide, please. So we have 2 slides per recommendation. And the first recommendation is invert the power. Affected communities and local actors are closest to the need. They act fastest. They are the most accountable to the people they serve, and yet they still remain at the edges of decisions about their own crises. A health official in DRC told us, decisions are often made in the capital or internationally, far from local realities, which leads to delays. That is not a flaw at the edges. That is the system and how it has been designed. Success cannot be measured by whether communities were consulted. It must be measured by whether they control priorities, resources, and accountability. Next slide, please. So here's some examples of the key actions under invert the power. First, apply a crisis typology, which we've spoken about, and the decision matrix. And then I'll go over the decision matrix in the next slide. The different crises need different responses. How you're going to respond to an acute emergency cannot be managed in the same way as a crisis that's been ongoing for 20 years. And a protracted crisis should not be treated as a permanent emergency. Secondly, make subsidiarity the default. So decisions should be made as close as possible to people affected by those who are legitimate, capable, and trusted locally. The question is not which international agency leads. It is who is closest to the crisis is best placed to lead. International leadership should be the exception, should be time-limited and linked to a clear handover and benchmarks. Safeguards must ensure power shifts to communities and not simply to the local elites. Third, simplify the architecture. Today's system is far too fragmented, competitive, and too slow. There are too many UN agencies, and I spent 15 years with UNHCR in Geneva, still one of my favorite agencies, but there simply are too many UN agencies and too many international NGOs involved in responses, particularly in the acute phase, because that's where the money is. They compete for the same mandates, resources, and visibility. So we're recommending the creation of a leaner, integrated, and accountable operational UN entity. One UN entity, not a specific one, but a combination that is operational in nature and that is much smaller than occurs now with all of these UN agencies responding. We also recommend replacing the cluster system and the refugee coordination model, which are consensus-based, to a fit-for-purpose incident management system, particularly in acute settings. Again, averting the power is not a slogan. It has to become the operating default, so decisions, resources, and accountability move closer to affected people. Next slide, please. So here's a decision matrix that we are presenting, which turns subsidiarity into a practical tool, and it asks 4 simple questions. Number 1, what do communities define as their priorities, and who do they trust? You'll note that we use authority. We don't use governments, because in many situations, governments are not controlling their land, their territory. So there are a lot of de facto authorities, Yemen, Libya, many places. So second, who has the authority, legitimacy, and the ability to protect people? This may not always be the governments, as we know, and in some situations, there may actually not be authorities in place who have the community's best interests at heart. In that situation, the international community will have a larger role than in many situations where there are actually authorities. Third, who is already delivering care? Local NGOs, faith-based providers, private providers, informal systems, or national institutions. Most of those are there in acute and protracted situations, and they have the capacity. They just haven't been given the possibility to do so because of the current system that is so focused internationally. And only then should international actors enter, and only to fill a clearly demonstrated time-limited gap with handover of benchmarks from day one. And fourth, can the health system hold, adapt, and recover over time? External leadership should be the exception, not the norm, and it must always have a clock on it. Next slide, please. So the next recommendation, 2 out of 4, is end impunity. Enforcement of international law is selective at best, accountability is absent, and civilian health workers pay the price. A health official in Burkina Faso described the impossible position medical workers face. If I treat a member of an armed group responsible for killing my brothers, it tests my patriotism. If the government finds out, I could face repercussions. Yet if I report it, I risk being seen as an enemy by the armed groups, which could endanger my life. The laws already exist: international humanitarian law, international refugee law, human rights law. We had a large group of mixture of lawyers, humanitarian practitioners, and it was concluded that these laws are adequate. They could be improved, yes, but now clearly in this geopolitical situation, now is not the time to make changes to these laws because likely they will be watered down. The Security Council Resolution 2286, passed in 2016, was meant to protect healthcare in conflict. Now, a decade later, that Rubenstein, who's here, was just speaking at the UN Security Council on this a few weeks ago. The follow-up has been limited, accountability remains weak, and impunity persists. An attack on a hospital should trigger consequences, not another statement of concern. Next slide, please. So here are some examples of some key actions. First, we propose to create a global health protection alliance. This idea has been around and people are working on it. Standing platform of states, UN entities, and NGOs that act in a systematic way when health protections are violated. The response can't be one or the other. It needs to be a combined diplomatic, legal, political, and operational. And it can't just be another cycle of statements of concern. Second, we reaffirm humanitarian principles are sacrosanct and update what is missing. So we reaffirm that humanity and impartiality are non-negotiable foundations of humanitarian action. Relief based on need without adverse distinction. This is written into international humanitarian law. Neutrality and independence remain essential, but they are operational principles. They are not legal preconditions for protection under international humanitarian law. So what we're proposing is that neutrality and independence depend on an organization's mandate. Obviously, ICRC will always follow independence and neutrality, but many local NGOs may not, and they should not be penalized, particularly for funding, if they're not following neutrality and independence, but upholding humanity and impartiality. And today's crises also demand 3 additional principles. So we're proposing on top of humanity and impartiality, do no harm, which is a medical principle, but we've seen a lot of harm occurring by humanitarian workers. So do no harm, solidarity, and accountability. Third, we propose to use health outcomes as accountability indicators. Excess mortality, service disruption, and inclusion should trigger formal investigations. They should not be accepted as the inevitable cost of war. Next slide, please. Third recommendation is fix the money. Humanitarian financing is still far too short-term, too earmarked, too donor-driven, and too shaped by foreign policy. A local NGO field coordinator in Turkey told us, this is a field largely shaped by donors. We do whatever the donors ask us to do. If a donor says psychological support will not be provided, NGOs generally do not reject this. This is the problem. Funding decisions too often determine what counts as need, instead of needs determining where funding should go. Humanitarian financing has increasingly become a foreign policy instrument. It always was, but it's becoming more so now. Bilateral and interest-aligned arrangements are expanding and becoming transactional, while multinational humanitarian finance is being cut. Humanitarian aid must follow need, not politics. Next slide, please. So here are some examples of key actions. We propose creating an independent, multi-layered, pooled humanitarian fund with government separate from UN agencies and bilateral donors, meaning OSHA would not run such a pooled fund as occurs right now. Allocations must be based on assessment, need, and equity, not institutional mandates, donor presence, or visibility. And we have some colleagues who will talk about this in more detail in panel 1. Second, expand cash-based assistance, where I think many people agree. The evidence is very strong. Cash gives people agency. It strengthens local economies. It is often more efficient. And cash is not uniquely risky. In-kind assistance can also be diverted. The issue is not the modality, it's the targeting, monitoring, and the accountability. Third, integrate humanitarian financing with national health insurance and social protection systems, particularly as soon as possible, but particularly in acute on protracted and protracted settings. Many refugee settings at this point, especially camp settings, have been stable for decades. My first, to show how old I am, my first humanitarian experience with the Médecins Sans Frontières in 1992 in Kakum, a refugee camp. Still there, bigger than ever. We need to be able to move those parallel structures. To move them into integrate them. They're costly, duplicative, and they often exclude displaced people from systems that they're entitled to use. And fourth, we need to use innovative financing tools, including responsible private sector engagement, anticipatory financing, blended finance, disaster risk insurance, and public-private partnerships are useful starting points. But, and I've actually worked with IRC on this early on a couple of years ago, they must be adapted for conflict displaced populations. Some of these systems that we have now with parametric indices work for natural disasters. They don't really work very well for conflict, which is more difficult to assess the risk. Next slide, please. Finally, our fourth recommendation is to uphold health for all. Universal health coverage is one of the great global commitments of this century. But crisis-affected and displaced populations have often been treated as a humanitarian carve-out, managed through parallel systems instead of being included in universal coverage. Parallel systems become obligations, they are expensive, they duplicate national capacity, and they leave host populations behind. A refugee in Azraq camp, Jordan, told us, there are many Syrian refugees in the camps who are in medical fields, nurses, doctors, pharmacists, dentists, and lab techs. If they were given professional practice licenses, they could work within the community and help improve services. This is a policy failure, and it can easily be fixed. War does not suspend the right to health. It actually makes it more urgent. Next slide, please. So here are some examples of key actions. First, make the right to health the test for every decision. Service delivery, coordination, and transition should be judged by one question. Does this expand equitable access for those most in need? Women, children, older adults, and people with disabilities must be prioritized, not left behind. Second, ensure continuity of care connected to national systems when appropriate. It won't be possible everywhere. Trauma care, safe delivery, vaccination, mental health, chronic disease care, and rehabilitation can't wait for the crisis to end. Humanitarian health services should align with national health systems from the start when feasible. Third, treat attacks on healthcare as crimes, not tactics of war. Protecting hospitals, clinics, ambulance patients, and health workers is a shared obligation across states, non-state actors, and the humanitarian system. And fourth, build health systems for climate shocks and responsible technology. Conflict and climate shocks obviously are no longer separate emergencies. Technology, particularly AI, has huge potential, but only if it's used with safeguards for equity, data protection, and human oversight. Technology must serve communities, it shouldn't extract from them. Next slide. So in summary, our diagnosis is clear. Incremental reform is not just inadequate, it's futile, and it's actually dangerous. It gives cover to a system organized around donor control, not around affected persons' lives. However, the current extremely difficult and dispiriting geopolitical situation that we're in, it now creates, I think, a rare opportunity, at least the Commission believes so. The humanitarian reset, the UN80 initiative, the ACRA reset are all happening at once. For the first time in decades, the system is unstable enough to truly be remade. The question is whether we use this moment to protect the status quo or to build something better. A health professional in Syria told us the real issue is that some donors not only expect you to remain neutral, but also threaten to suspend your funding if you show any perceived bias towards the victims. That is the system we currently have. The 533 lived experience voices that shape this report are not waiting for another reform discussion. They're waiting for protection, accountability, and a system that treats them as equal actors. This commission is not only a diagnosis, it's a demand for transformation and a blueprint for action. Next slide, please. In the CHH Lancet Commission website, we develop policy briefs for all in terms of how affected persons, communities, international actors can use this commission to actually make for change. And here are just some examples. Affected populations need to claim care, rights, data control, and accountability. Local NGOs and national NGOs need to assert their leadership and demand equitable partnerships and real cost recovery, not just be treated as consultants. International NGOs must enable local systems. They must transfer power and resources to local and national NGOs. UN and multilateral, they must slim down, coordinate, stop competing, and they must let go of power. And donors need to pool funds through predictable multi-year and depoliticized financing, amongst other issues. Next slide, please. So this is the last slide. The full report is published in the Lancet and on the CHH Lancet Commission website. The QR code on the screen will take you to it. I'll close with the voice of a senior NGO staff member in Turkey. After addressing immediate needs, the momentum waned. Promises were made, but once the initial phase ended, support diminished, leaving people feeling abandoned. Our job, every one of us in this room, is to make sure that this time the momentum does not fade. This is a once-in-a-generation moment to truly transform humanitarian health assistance. And I hope that we can seize it together. Thank you. So it's now my pleasure to introduce David Miliband, who's the president and CEO of IRC, the International Rescue Committee. David leads one of the world's major humanitarian organizations and previously served as the UK Foreign Secretary. David, thank you.
Thank you very much, Paul. Good morning, everyone. Very good to be here. This is a rich report and a powerful report, and it's also a timely report. I think it's important to emphasize. Of course, as we're meeting people in Eastern DRC are facing a renewed Ebola outbreak. This emergency, I think, is a reminder of how closely health outcomes are tied to conflict, to displacement, to fragility, and to international support. In fact, I would make the argument that although the report mentions the word inequality a lot, it doesn't actually say that the greatest inequality today is whether you're born in a conflict state or in a stable state. But actually, if you look at life chances, that is the biggest divide. Yet at the same time as this emergency, we know that as needs are rising from Sudan to Gaza, the great aid recession of 2025 has cut ODA by nearly a quarter. Whatever those statistics are mentioned, and Paul, you did a good job of mentioning some of them, let's remember remittances are 3 times the aid budget. Debt repayments are many, many times the remittances or the grant aid budget. So the financial flows that affect poorest people in the world are multiple, not just singular. I thought you've been asked me to speak for 10 minutes, and I'll try not to do the ex-politicians thing of therefore speaking for 35 minutes. So I want to pick out just a few elements of the report. I can't do justice to all of it. At the heart of the report is the insight that the current health and humanitarian architecture faces an inflection point. And I think that's right, and it's worth trying to diagnose why. 60 wars, chronic and mixed displacement. There's not much emphasis on mixed displacement in the report. A climate crisis that will only deepen. Rising impunity for civilians and for aid workers. Thank you, Paul, for you and your colleagues giving so much emphasis to the impunity that exists in conflict zones. These all represent a new quote-unquote normal. But I don't think we should be under any illusions that a new normal is not an equilibrium. Either we arrest the slide or it will accelerate and spread. Obviously, the real solution lies in politics, because while humanitarian aid can stop the dying, it takes politics to stop the killing. That's actually my old beat. And the report doesn't shy away from calling out the importance of politics to countering the impunity emergency that exists in war zones around the world. I applaud that. As I say, it's my old stamping ground. But the report also faces head on what is in our power to address, and it's what's in our power to address that I want to focus today. For years, humanitarian discussions have been framed around what I see as false choices: global standards versus local adaptation, humanitarian versus development aid, evidence versus context, and also local organizations versus global organizations. Too often, the people who need the most help, IRC's clients, are actually left out of the debate. This report, I think, can help address that, because these clients face different contexts. It may seem obvious to us, but it's so rarely said. The demarcation between acute widespread crisis, where there is no government support, and just to put a parenthesis on something that Paul referred to, numbers of people living outside traditional government authority, 200 million of the billion people living in fragile states are under the control or the authority of non-state actors. So there are there's places of acute widespread crisis. There's places of protracted crisis where government is weak or in conflict with local actors. And then there are settings where displaced populations can be served by local and national systems. I really welcome this delineation. I think it's the source, it could be the source of real wisdom. It has implications for the way the sector works differentially across those different contexts. In each one, there are many actors, the prime actors being local actors, but also UN agencies, government ministries, international humanitarian organizations. But the missing actor is often the people themselves. I just want to put a particular point on that. When we say accountability has to flow to clients, the people who are most affected by crisis, often we hear talk about quote unquote country leadership being central. I understand where that vibe or that demand is coming from, but I also remember that President Assad always said he was providing country leadership for Syria. That's why I like to talk about whole of country leadership, not just country leadership, to put a pin on the point that not all governments are representative of all of the people who live within their authority. Whole of country leadership, including those marginalized by conflict or politics, should be the goal. Just briefly, the report pushes for pooled funds, cash-based assistance, and innovative financing. That seems to be right. Pooled procurement can reduce costs. Cash and voucher assistance can empower clients. And innovative financing has the potential, and I underline potential, to crowd in private and concessional money in more stable settings. I can't tell you how many seminars or conferences I've been to where the prospect that the private sector is going to arrive at the rescue of Sudanese people who are suffering from aid cuts is put out there as a kind of, I don't know, it's like a hallucination. In fact, it's never actually going to deliver, but it's words that people say. What I want to put a double pin in, though, or underline, is aligned outcomes for all the players in the different context, shared metrics and reporting systems, and real transparency over cost. I think it's not unfair to say that cost effectiveness and cost efficiency is not something that is a major theme of the report. I feel there's a moral argument as well as a political argument for us as part of this sector to own the passion for cost effectiveness and cost efficiency, because it means more people can get help. The IRC has done 400 cost efficiency and cost effectiveness studies in the last 10 years. You can see them on our website. It staggers me that there isn't more emphasis from our own sector on that. I'll come back to it. Every IRC program is organized around key outcomes. That's how we put clients at the center. And I promise you, aligning around outcomes challenges dominant systems because those systems are not organized around outcomes. For example, a focus on outcomes can put reward on anticipatory action rather than late response. It puts evidence-based interventions at scale. It also drives incentives for efficiency, effectiveness, and innovation. A focus on outcomes also means concentrating resources where they're most needed. I was really pleased, Paul, that you emphasized the 10 countries with the most IDPs. We have a data-driven list of the 20 countries most in humanitarian need. They account for 89% of the people in humanitarian need, those 20 countries. Yet they receive, and we all know, I hope, 60% of the world's extreme poor live in fragile and conflict states. Yet if you look at, however you run the numbers, it's about a quarter of the overall aid system that goes to those places. At the International Rescue Committee, as an unusual organization that is only focused, a unique organization, that's only focused on people whose lives are shattered by conflict and disaster, we see our job as more than, quote unquote, delivery. We want our research and evidence to take away the excuses from policymakers that they don't know how to achieve, that we don't know how to achieve impact or how to achieve cost effectiveness. If you'll permit me, I just want to give 3 examples because it's more than cash assistance that we know works. But first, when we launched our vaccination program with Gavi in 2022, our goal was to immunize 0-dose or low-dose children in Chad, Ethiopia, Somalia, Nigeria, Sudan, and South Sudan. Only 16% of the 156 target communities were accessible to health actors. Through a combination of negotiations with with rebel groups, quote unquote, through portable vaccine carriers, our consortium, IRC, also many local actors, has delivered 30 million vaccines to 2.5 million kids in 100% of those communities. Through scale, we drove efficiency. The average cost per dose started about $3.75 in year 1. By 2025, it averaged less than $1 a dose, well below UNICEF's benchmark standard of $2.34. We're now using technical innovations in satellite mapping and route mapping to reach even more children at lower cost. Second example, anticipatory action in the face of climate impacts that hit everyone hard and those in fragile contexts the hardest. Remember, adaptation funding is inversely proportional to wealth. So the poorest countries in the world that are often the most climate affected get the least money for climate adaptation. More than 1/3 of health facilities we know of lack basic water, more than 3/4 lack basic sanitation, and more than half lack basic hygiene. By integrating climate forecasting, disease surveillance, and operational data, IRC teams have been able to trigger earlier water system rehabilitation, reposition hygiene supplies, and expand community outreach before drought and flood-related outbreaks escalate. I think this anticipatory element is absolutely key. The only government I know of in the world that has a commitment to fund anticipatory action is the Germans, who said that 5% of their funding should go on anticipatory action. We need that to be much broader. Third, Paul, you mentioned AI. We're currently field testing an AI-powered diagnostic tool to support the detection of mpox. This is one of 200 different rare diseases in Africa that are not properly mapped. I want to try and get this right. I think the following is right. That the strain of Ebola that that wasn't properly diagnosed, the Zaire strain, is picked up in the tests. The current strain that is afflicting Ebola, people in the DRC today, is not picked up by the tests. I think I read this morning that there were 234 cases of this new strain last year. But there was no follow-up to it. So there was no development of the testing regime. And I was involved with the International Panel on Pandemics, Preparedness and Response. And one of our recommendations was precisely to do this sort of real-time development of the tests so that we were able to do a better job of preparedness. In each of the three examples I've given you around vaccination, around anticipatory action, around AI for health diagnostics, we work with a unique context-tailored combination of local and global actors. And that allows us to collectively drive forward to better solutions and outcomes. The way we see it, there's expertise locally and there's expertise globally. And our job is to bring them together. I really think we have to avoid making localization a zero-sum game. You can say, well, in the end, who gets the money? But when we have choice about our money, we actually give it to local actors. Our overall average is 25%. Places where we raise our own money and are not tied by some of the bureaucratic systems, we get it over 50%. But in a whole range of areas, it is positive sum rather than zero sum, and the vaccination case, I think, speaks to that. I know, let me finish up, I know that writing reports is difficult. Writing good reports is even more difficult, and this is a good report. However, as Richard, the editor of there were two editors of the Lancet, he's the Uber editor, or I don't know, one of the two editors of the Lancet said, turning good ideas and insights into practical action is actually harder than writing reports. This is especially the case when arguing for systemic change involving multiple actors. And if you'll give me an extra 30 seconds, Paul, you said, I don't want to misquote you, that to be incremental is futile. I don't think that's quite right, if I may say so. Because in the end, change is always going to be gradual, but our clients can't afford it to be slow. And I want to draw a distinction between something being gradual and something being, you can be gradual and fast or incremental and slow. And in my book, what your report does is establish a vision. So my, not correction to you, but my gloss on what you said would be that incrementalism is only futile when there is no vision, but gradualism can be real when there is vision. And I think what your report does is provide a vision, because in the end, there are going to be so many decisions that have to be taken by so many actors that it's inevitable that change is gradual. But you've provided a benchmark against which to judge decisions. At the IRC, we're trying to embody the future, not just debate it. We've had $400 million of funding cuts over the last year, probably more actually now. But we've protected our commitment to impact evaluation, to innovation, and to cost effectiveness. In fact, we've doubled down on those three elements because the outcome we seek for the people we serve cannot be achieved without the impact, the innovation, and the cost effectiveness. In our book, in my book, that's the way to move beyond not just the false opposites that this report seeks to counter, but also the cruelty and neglect that it seeks to overcome. Thanks very much indeed.